start, and if people more join, then it's a cases, so they will miss cases. So I will present the case, and either you raise your hand or text me if you want to answer. And please try to be in a quiet room or use a headphone when you want to talk. Just don't to be like very disturbing for others. So we'll start with the first case, and we'll see who like to answer the question. An 8-month-old girl has fever with difficulty in breathing and swallowing. And this is the X-ray. Anybody want to answer? Again, an 8-month-old girl, 8-month-old girl has a fever with difficulty in breathing and swallowing, and this is the X-ray. Any comment? Anybody want to answer question? Anything? No? We'll give you 30 seconds.
Do you hear me? Hello?
Yeah, go ahead, Sinan. Yusuf.
Okay, fever, difficulty in swelling, difficulty in breathing, mostly epiglottitis or bronchitis. We need to know if there is salivation, excessive salivation.
Well, the idea, Yusuf, the idea is to look to the X-ray. So you have that history, and what do you see? Because that's the whole point today, is not to do differential diagnosis based on clinical. It's only based on the X-ray. Do you see anything on the X-ray that suggests anything for you? So 8 months. Difficulty in swallowing, difficulty in breathing, and this is the X-ray. And there is 2 arrows, one is big one, and there is a star. Yeah, you can unmute yourself and answer if you want.
Is this adenoids?
This is adenoid, very good. Yes, very good, well done. Very good, yes. No, this is adenoid, very well. So the X-ray showing it's a lateral view, and we're looking at the neck, and there is enlargement of the adenoid. Look at, it's up, it's not epiglottis, it's not below the jaw, okay? And it's not related to the vertebral column, so it's not epiglottitis or pharyngeal tissue involvement, because it's not related to the vertebral column. But there is enlarged lingual tonsils, there is big tongue, if you look at the tongue, and there is, if you see the nasopharyngeal airway, I don't know whether you see it or not, it's actually very tiny, and that's the reason why we have, and I have a fever. So, okay, can you, whoever open, can you mute yourself? Just unmute yourself when you want to talk. Surah. Thank you. Surah, mute yourself, please. And Aya, mute yourself, please. Aya, mute yourself, please. Use the headphone or AirPlug.
First time. So sorry. مش عارفة أعمل إيه.
Okay, so it's enlarged adenoid, very good. Now case number 2. A 1-year-old boy presents with head injury after fall from about 3 meters. And this is the CT scan and 3D constructed CT scan, the below one. Any comment? Any comment?
I think, okay, this is a Extradural hematoma.
Extradural hematoma with what?
With subglial also hematoma.
There is subglial, subgalial, maybe, not sure.
With a fracture. With a fracture of the bone.
Yeah, there is extra-axial swelling, and there is another collection below the bone, and there is a fracture. And the fracture very clear on the one on the top right upper, and on 3D construction there is very clear fracture. So yes, there is a swelling outside, there is connection inside, and there is a fracture here. Can you mute yourself, please? Whoever is, just mute, unmute yourself. Just we need to practice that. Yeah, so this is without contrast. This is a CT, and you can show a spontaneous hyperdense, and it's a lentiform. And you can see it's a lentiform shape, so it's seen from outside, it's not from brain. And it's an epidural hemorrhage and is associated with cephal hematoma or whatever outside swelling. Okay, I'm gonna add this person because he's insisting on entering. And Kuko Dudo, do you hear me? Kuko Dudo, do you hear me? Kuko Dudo, do you hear me? Now, is this your real name, Kuko Dudo, or this is a fake name? Kuko Dudo, if you don't answer, I'm going to remove you from the meeting.
I'm sorry, I will change, okay?
So yeah, please change to your name so we know who you are talking, okay? So I'm gonna remove you. When you change, go back inside. Okay, so again, there is extra swelling. I'm not sure whether it's a cephal hematoma or subgalial. It's hard to know without clinical exam because there is a limitation. So I don't know whether this limitation is just not progressing or it's a real sutures limitation. So it's hard to say whether it's a cephal hematoma or subgalial, but it looks like extraaxial, and there is lentiform swelling here, and there is a fracture. Okay. So this is the diagnosis. You guys were right. 2-month-old boy present with an abnormal shape of the head, and this is the X-ray. Any comment? We give you 30 seconds to comment. You can see it's an X-ray, AP and lateral view, and you can see arrow trying to bring your attention to that area. Any comment? No? No answer? Well, let me answer the question then. Oh, I have a comment. Craniosynostosis. Yeah, it's a good one, but you mistype it. That's okay. Nihal. What type of it? Yes, very good, Uthman. Uthman measured this. Very good. It's a fusion of metopic suture, and it's a craniosynostosis. That's very good. So it's a premature closure of anterior parts of metopic suture, which run from the top of the head at the anterior fontanelle, resulting in deformation of the anterior portion of the calvarium and a triangular shaped forehead, what we call it trigonocephaly. Yes, yes, Uthman, you typed it very well. Well, you missed some letters, but it's okay. So remember, when you go to exam, make sure that your spelling is correct. So it's Craniosynostosis. And look at the spelling. Whoever texts me, that is the correct spelling. Okay, we have one more person joining. That's good. Oh, another one. Oh, good. So case number 4. A 2-year-old boy has fever, sore throat, dysphagia, neck pain for 1 week. The patient recently developed paranasal sinusitis and otitis media. Again, 2-year-old boy has fever, sore throat, dysphagia, and neck pain for 1 week. The patient recently developed paranasal sinusitis and otitis media. And this is the CT scan. Comment. Anybody? There is arrow trying to bring your attention to an area. There is lateral view and there is sectional view, transsectional view. Yes, Aya, go ahead. You can answer. Unmute yourself and answer.
Retropharyngeal abscess?
Retropharyngeal abscess, I think yes. Or parapharyngeal, retropharyngeal. Somebody said it's parapharyngeal, yes. Both are correct, I think, retro, para. Although para is from the side, not anterior, but yeah, it's an abscess. It's an abscess. You can see a hypodense area surrounding by well-circumcised boundaries. It's very close to the vertebral column and it's below the mandible, so it's related to the pharynx. Yeah, axial and sagittal CT scan image of the upper neck with contrast reveal hypodense oval collection in the prevertebral space with peripheral rim of enhancement and which suggestive of retropharyngeal abscess. Okay, case number 5. A 2.5-year-old girl was transferred to a hospital with a serious head injury after falling from 2nd floor to the ground floor. And this is the CT scan. Any comment? Give you 30 seconds.
This hematoma?
What can you describe, Ilham or Ilhama? Can you describe rather than give the? Remember, always describe. Don't give diagnosis because you will be wrong. So don't jump to diagnosis, but try to describe what you see. Even if you don't know the term, just describe it as you describe your dress or when you buy shoes. Just describe it.
Okay, doctor. This patient, according to X-ray, looks like a frontal
frontal lesion. Yes.
Yeah.
Right.
I feel that
intraaxial collection, right?
Sorry, I don't know these names clearly.
Yeah, this is it's the collection within the skull. It's not outside the skull. So it's intraaxial, not extraaxial, right?
Okay, doctor. Okay.
Yeah, and there is here something. Do you see it?
Yeah, I feel that there is a fracture. Yeah.
There is a fracture. So there is a fracture in here. If you see the fracture.
Yeah.
Okay, and there is intraaxial collection, and there is few dots. Do you see these dots on enhanced CT? Okay. So this is an axial sagittal CT scan image without contrast, show intraparenchymal and subarachnoid hemorrhage and small subdural hemorrhage. So what we call this, I would call it intraaxial bleeding because there is different types of bleeding. There is there is inside bleed, if you see the dots, okay, and there is subarachnoid. And the difference here is the shape. You can see the shape is not lentiform, because it's within the brain, it's not within the brain, but it's within the arachnoid. So if it's epidural or subdural even, it will take the shape of the skull, not the brain, because it's outside the brain. And that's the way you differentiate it. So you can see multiple bilateral frontal and orbital fractures with air in the brain can be seen here.
That black dot is the air, doctor?
Yes, this is a, remember, X-ray, any CT scan is X-ray. So black is air. It's like exactly like air. And when you do 3 construction, you can see that. Okay. So final then, severe head trauma with subdural and subarachnoid hemorrhage. Okay, case number 6. We will go to the lung, and I have like 900 cases, but I don't think the time will permit. But I try to put the most important people usually put it in the exam. But I have 100. We can continue later if you guys want.
Okay.
Like not today. 15-year-old boy with a history of travel to South America presented with muscular pain, severe headache, and recurrent seizure. Okay, and this is his MRI, and you guys remember it's South America, which means like a developing country. And if you go back to history, it's a history of travel. There is muscular pain, there is severe headache, and there is recurrent seizure. Okay, somebody said Lyme disease, which is unfortunately incorrect, because can you tell me how Lyme disease developed? And where? Which country? Whoever said Lyme disease, who said Lyme disease?
Usually it's in the countries which is contained forest, and the disease is transmitted through a bug.
What is the bug?
Actually, I forget the name.
No, the name, but what kind of bug? I don't know the name, but what is it? Like it's a fly, mosquito, tick?
Yeah, it's a fly. Yeah,
it's a fly, or it's a tick.
Yeah, fly ticks. Yeah, it's a tick. Sorry, ticks.
Tick infection. So you get skin infection. It's target lesion, getting bigger and bigger and bigger. You get fever and all that sort of things. It takes a period before it develops to like a joint problem or brain neurological involvement. And the treatment is, and the name. What's the name?
Sometimes the patient even can start to have.
I think it's the name of the organism of microorganism is Borrelia burgdorferi.
Burgdorferi.
And also it is not in South America. It's actually in developed countries. It's in North America, like Canada and USA.
Yeah.
It's not common. It's not in
Australia. Sometimes also Australia. From that.
Sometimes Australia. So it's not Lyme disease then. What else? Any other suggestion? Ilhama? Just guys, describe what you see. There's T1 and T2 MRI. What do you guys see?
I see well-defined round shape.
Okay, so it's well-defined and it's inside the brain. What will be?
Looks like
maybe it would be sort of infarction or
maybe infarction will not be well circumcised, but it can be abscess or it can be
calcifications.
Well defined, right? And there's some calcification, I think, but it's well defined, so it's cyst, right? Either cyst or abscess. There is nothing else caused that well. The tumor will not cause like this. Stroke will not cause. So it's either cyst or
tumor.
No, cyst or abscess. Tumor will not cause like this. Tumor will be irregular border.
There is something called cirrhosis, or
that is
like
correct. This is the infection. This is an infection, and it's very common in developed country, Iraq, I think Egypt, all the North Africa and South America, and it is what we call it Neurocysticercosis or hydatid cyst, the other name hydatid cyst in the brain. Okay, so remember, when it's well remember, don't give diagnosis, just describe. If you describe, you will reach the diagnosis, even if you don't know. Like, just put a differential diagnosis. You don't need, from the x-ray, you won't able to say this is a Neurocysticercosis, but if you add the history to it, you can. And remember, it's like a puzzle. They're trying to give you a puzzle. It's an exam. You won't face this in your real life. That's why I hate the exams. Because it won't come like that. You will have more resources to reach to the diagnosis than this. Okay, well, case number 7, an 8-year-old boy admitted to our hospital after road accident.
So trauma.
So this is a CT or MRI, I think. Yeah, MRI of the spiral, and it's from the vertebral column, and you can see there is arrow here, there is arrow here. This is on a few hours, this in, I think, after 1 day, and this is after 7 days. Okay, so looking to comments. And remember, just describe, not, like, at least I would say, I'm losing the vertebrae. There is no vertebrae. There is vertebrae here, there is vertebrae here, there is no vertebrae in this area. On the T1. On T2 also, you can see the vertebrae is very nice looking. There is nothing here. Same here, there is disconnection between this and this. That, even if I don't know anything, I would say that, right?
Yeah. This is, sorry, Dr. Yahya, this is a lateral view of the neck?
Yes. So this is an 8-year-old boy admitted to our hospital after road accident. And this is not X-ray. I think this is, looks MRI. Like MRI. I don't know now, the MRI and CT scan sometimes looks like each other.
MRI.
That's kind of imaging. So what you guys see? Any comment?
It's a fracture because there is a displaced.
There is a fracture. Yes, there is a fracture. There is
Crushed vertebra.
There is a crushed fracture, and there is this dislocation.
Dislocated.
Yeah, dislocated vertebral column. So a few hours after the accident, CT scan of the neck was done, which revealed C2 and C3 dislocation with wide disc space and paravertebral hematoma. And the MRI image on the 2nd day after admission show dislocation with slight edema and spinal cord. And 7 days later, MRI revealed same dislocation, more prevertebral hematoma with apparent damage in the spine. I just put this just to try to tell you that you don't need to memorize. Sometimes just talk to yourself. What is this? What's the abnormality? Just describe it not in a medicine way. Just describe it in a...
Dr. Yahya, what is
Go ahead.
Dr. Yahya, where is the hematoma? There is a displaced fracture, but I cannot, I don't know what is exactly look like.
Look at here.
Yeah.
Look at here, which is the space between the vertebrae. Look at it. Okay, look at the color. And look at the color here. What do you see?
Like white color.
Yeah, a whiter, and you can see here. Do you see this?
Yeah.
So this is the hematoma, and this is the swelling. Hematoma here, because it's a fluid. And this is the swelling.
So hematoma will be a dark color in the MRI,
yes,
and
yeah, it's like the abscess because it's less dense, less density. Okay, so the diagnosis: severe neck dislocation with a progressive spinal cord injury. Case number 8: a premature baby present with sudden unexplained drop in hematocrit level and transfontanel ultrasonography ordered immediately. Okay, and this is, for people who don't know the ultrasound, this is a coronal view. It's an anterior fontanelle, and this is the right side, this is the left side. This is a sagittal view of one of the side. I think it's the right side, and this is some time later.
Okay, the white, can we comment?
Sorry?
Can we comment?
Yeah, go ahead.
With the coronal one, there is some white appearance, hyperdense or I don't know how to describe. It looks like
okay. So look at here. Do you see this?
Yeah.
This is choroid plexus. Okay.
Correct.
But choroid plexus end usually here. There is something like coronal plexus, this one and this one. And the codothalamic groove, if you know what is it's irregular. Okay, so irregularity of codothalamic groove on ultrasound of neonate, of course, this is my specialty, so that's mean IVH grade 1. But he can see that there is extra choroid, something like choroid, inside the ventricle. And you can see here, okay, it's increased density, okay, and you can see the other side of the ventricle, lateral ventricle, it looks normal with the fluid inside it. There is an interhemispheric fissure, which is not yet displaced. And there is a wide area increase in size, intra and parenchymal hemorrhage. And on the lateral view, you can see, in the sagittal view, you can see, because usually the choroid plexus is down. If you see this filled, with fluid, then it's also another bleeding going to the inferior horn, but you can see that there is no filling here. So the bleeding is less. So from this view, I would say it's less than 50% of ventricle are filled with fluid. And it's very obvious here on the right side, not yet displaced. And there is, I think this is MRI. There is a dilatation now and eating and hypertrophy of the brain and getting bigger size. So
And this?
It does not look like a hydrocephalus for me, but I might be wrong because there is no shift. It's more like, it can be hydrocephalus, but it's due to atrophy of the brain, not because it's a tension hydrocephalus. So it's, even if it's hydrocephalus, it's a communicating hydrocephalus because there is no shift. If it's non-communicating hydrocephalus, a tension one, there will be pushing the interhemispheric fissure to the other side. So it's extensive intravertebral hemorrhage with extensive extension to the brain tissue, as we said here. So it's not only bleeding, it's parenchymal and intraventricular. And the MRI a few months later showing complete resorption of the hematoma with local brain atrophy and dilatation of right ventricle. So it's not hydrocephalus. That's very important to remember when you do head ultrasound. Unfortunately, I was planning to do a head ultrasound course, but because of the novelty of people in technology, we couldn't continue. So this is non-communicating hydrocephalus, or what they call dilatation of the ventricles. Okay, case number 8, diagnosis is IVH grade 4 hemorrhage. Now, case number 9. A 2-year-old boy present with a progressive projectile vomiting. Clinical exam showed by papilledema and swelling of the left side of his head. A right suprarenal mass was recently discovered on abdominal ultrasound. Oh, you can go wherever you want. That's, you don't need to excuse yourself. You can leave anytime. So again, 2 years old, progressive vomiting, papilledema, swelling of left side of the head, and there is suprarenal mass on ultrasound. And this is
neuroblastoma.
Neuroblastoma, very good. What I discovered when I went back to Iraq after 15 years from visiting, I thought people there very good in rare diseases. They're very good actually. They can discover anything rare. But they are not good in very common disease. They don't know how, for example, to use a mask. They don't know how to intubate or ventilate. They don't know how to calculate fluid. They don't know how to treat asthma or gastroenteritis properly. Sure, now they don't know how to save life. But they're very good in rare diseases. They're not good in sepsis, an infection, but they're very good, for example, in thrombocytopenia obliterantata or something like that. Never heard in my life. But when you tell them how you treat HIV in neonate, or how you treat hepatitis, or how you treat sepsis, or how you select antibiotics, what's the difference between early, late onset sepsis or late onset sepsis? What's the difference between this bug and this bug? Why use clindamycin? Why you don't use amoxicillin? Why use this? They don't know. Very, very strange. But if you ask them about Krausen disease, they're very good. They know everything about it. Something like that. So you guys, yes, neuroblastoma is a rare problem. I'm not saying that you should not know it, but you're very good in these rare diseases. So yes, this is a neuroblastoma. You can see a mass here, and you can see also the mass here. So it's a hyperdense expanded left parietal epidural mass with extracranial extension. Where is the extradural extension? Is not clear on this actually. Not clear, I don't see where. Window CT scan lytic lesion in the left parietal bone. Oh, where is the lytic lesion? I don't see it. I don't know, is it this? I'm not sure what is it. Anyhow, case number 9, so it's a neuroblastoma, that's correct. Okay, 10-year-old boy presented with 2 months history of headache, a recent history of vomiting, ataxia, papilledema, and was seen on the exam. Okay. And I think I'll leave this case. I think I did something wrong. Okay, let's go to number 11. Okay, Dr. Muhammad Mih, Dr. Muhammad, Dr. Muhammad Yusuf, can you please remove the word doctor from your name? We all know we are doctors. You don't need to put doctor. And it gives me a hard time to find you when you put any letter with your name. So please log out, remove the word doctor, the prefix doctor, the salute from your name, and log in again. Thank you. Yeah, that's correct. But it just because the same picture, I did something wrong with your representation, I removed it. Anyhow, a 5-year-old girl presented with short neck, low hairline at the back of the head, and restricted mobility of the upper spine, along with standing torticollis. And this is the X-ray, the MRI, and the constructed one, CT scan. And to be honest, I won't diagnose this myself. So, but I put it just for the exam. But if somebody asks me, I won't able to diagnose it. Any comment?
There is compression of the spinal canal, what I see. If,
okay.
Which one the arrow is showing, there is compression with some extra bone is there, something like that, yeah. But I don't know.
Yeah. Lily Mark, Lily, well, first your typing is not proper one, because Turner starts with capital, and syndrome there is E. Second, don't jump to, that's my advice to you, don't jump to diagnosis, just describe first what you see. You might be correct, I'm not sure, but just try to describe. Yeah, who, sorry for interruption, who was describing?
Me, Dr. Yahya.
Yeah, go ahead.
Yeah, there is a compression of the spinal cord into two regions with maybe some extra bonus there, something like that, if I'm right.
Oh, okay. Oh, okay. Oh, okay. So let's see. Lateral X-ray view of cervical spine showing fusion of cervical vertebrae and tracheal deviation to the left side. So this is the trachea pushed to the left side, and there is a fusion. You see this is not fused, this area is fused. Is it clear? So there is here, and there is a fusions of the vertebrae.
Dr. Yahya, what is the beside? You are telling there is a deviation of the trachea to the right. What is the beside this black color?
This one?
Yeah. What's that? Air?
This is the, I think the esophagus. Esophagus or the larynx, that area, like something either the trachea or the esophagus, because the trachea is here. It's yeah, like when you do, if you know how to do ultrasound to check the intubation, so it's like a goose sign if you heard about goose sign, or double trachea sign if you heard about it. When you do an ultrasound to make sure that you're intubated, you do an ultrasound of the neck, and then you look if you have one trachea or two tracheas. If you have two tracheas, that means your tube in the esophagus, and the trachea is, there is air. So it's because the trachea is deviated to this side, you can see the esophagus. I think this is the esophagus.
Okay.
Or the pharynx, something like that. But it's not the larynx, definitely. Okay, so there is no compression. I don't think there is a compression, but I'm not good at that. You might be correct. So the diagnosis is Klippel-Feil syndrome. And I'm definitely not good in this Reps diseases, but I put that for example. Okay, so 2 weeks old preterm infant born at 28 weeks presented with tachypnea, tachycardia, increased respiratory fault with retractions, nasal fraining, grunting, and frequent desaturation. And this is the X-ray. So please don't give me diagnosis, just comment. There's two X-rays. There is one, I think, early in life, and there is one later in life.
Mm-hmm.
So I want you to comment. And I'm going to give you advice how to comment on the X-ray. There's two ways to comment on the X-rays. Chest X-ray. Either to start from outside and then you go to inside, or you start from inside and you go outside. And remember to comment on the lung, any extra devices connected, heart, and then diaphragm. Remember, the ribs, you need to comment on the ribs, and then extra soft tissue. Okay?
Yeah.
Okay, any comments?
This X-ray, is it centralized?
Okay.
It is AP view.
It's AP view, you mean?
Yeah, it is AP view, yeah.
What is the difference between AP view and PA view?
Anterior posterior, I think you will see the heart shadow will be compared to posterior, it will be larger.
I know it's AP view, anterior posterior, but what's anterior posterior means in X-ray? From where is the film and where is the X-ray beam? That is my question.
In AP view, the film will be in the back side and exposure will be from the front side.
Okay, so AP or PA describe the direction of the X-ray beam.
Okay.
Okay, so in neonate, you will never have PA view. It's only in adult, because you have to get your shoulder like this and grab the X-ray film, and the X-ray will hit you from the back. So it's always AP view, because the X-ray, the film will be on the back. So that's an AP view. You're right, there is no very well oriented X-ray. Yeah, what else?
We will go like A, B, C, D, right? Airway.
Whatever you go, just don't forget. You can go from inside, outside. You can go from outside to inside. You can start by system. So you'd say, I will comment on the airways. Yeah, go ahead.
Airway, I see there is a ETT tube.
You see ETT tube, yes.
The position, it is above the carina.
Above the carina, okay.
And it is...
What's wrong with the ATT?
I feel it is a deep little bit.
It's deep. So how you know it's deep?
Because it should be above the carina, but it is just touching the carina.
No, not like that. That's sometimes difficult in babies when they flex their neck. So when the baby flexes their neck, it will look like, or extend. If they extend, it will go up. When they flex, the neck goes down. So yeah, you are correct. It's above the carina, and you can see it's at the bifurcation of carina. But you calculate the distance between the clavicle and the end of the ETT. Okay, see the distance. It's so huge, and you can see 1, 2, 3, 4 ribs. No way, that's very long, like very deep. So you are right. It's very deep, but still not yet selectively intubated one side. That's very good. So you need to be pulled, and you need, I think it's about 1 centimeter. You need to pull it back. What else wrong with this X-ray?
I see like
Anybody else than Ilhama? Everybody is listening. Just contribute so the discussion will be worth. People.
Yeah, it's looks like there is atelectasis, like small area.
Oh,
black.
don't go to that point. I told you. Just describe what you've seen.
Describe.
Yeah. So I'm going to describe it for you. Is that okay?
Yeah, for sure. Yes.
Yeah. So first, there is ETT, which is deep, reaching the carina. Second, there is chest tube, which is very, very, very badly positioned. The TT tube is coiled inside the chest. Okay, so it's very badly inserted chest tube. It's inserted, I think, in the 4th or 5th intercostal space and directed toward the head and then coiled inside, badly positioned. That's one. Okay, there is some monitors on the abdomen that I can see, and there is no feeding tube. That's very important. There's no feeding tube in the X-ray. The chest X-ray, if you look at the ribs, if you look at the ribs are compressed. So if you can see the ribs, the spaces between the ribs are compressed. It's not well shaped. So it looks like underinflated. And also you can see the diaphragm is going up. Okay. The other important, it's very hard to differentiate between the right side of the heart and the lung. So the cilia of the heart on the right disappear. Okay. So, and then the number of ribs, if you count them, 1, 2, 3, 4, 5, 6, 7, 8, 9. So this person is going very high PEEP. So I think the PEEP here is almost 10 or 11 because number of ribs. However, the lung inflation is not good because I cannot see the border of that. I can see it, but it's not very good. It seems that there was pneumothorax and they inserted the chest tube, but it disappeared. The right side of the heart looks okay. I can see it. Okay. I don't see asymmetry, like a heart, like the lung is symmetrical. And also I see subcutaneous emphysema, probably due to insertion of the chest tube in here and in here. Okay. So this is an early. Now you can see the tube is still deep. Okay. But the X-ray position is not correct. The X-ray taking more from the right side. So we see right more than left. And you can see here, that's 1, 2, 3, 4, 5, 6, 7. So it's underinflated lung. And also you can see you cannot see the diaphragm, you cannot see the heart, right? The cilia of heart disappeared. So there is complete either atelectasis or collapse, or you're losing the alveoli. Your tube is very deep. You can see there's probes here. There's 1, 2, 3. There is yet no feeding tube again. There is no good aeration of the bowel. There is distended stomach. You can see large liver, and there is there's like a fixed bowel loops. I don't see the very well bowel movement. So in my view, this is poorly ventilated patient, poorly attached ETT, poorly inserted
chest tube,
resulted in chronic lung disease. Now, chronic lung disease is a clinical determinant, but the pathology would be PVD. So this is bronchopulmonary dysplasia. Does that make sense to you?
Yes.
Yeah. So chest right shows over aerated lung with diffuse robe-like density separated in some areas by hyperlucent zone. After a few days, density become coalescent in many areas, and heart border are completely obliterated, not the malposition of endotracheal tube and the thoracic drain for pneumothorax. So this is PPD. Okay, case 13. A 6-year-old boy presented with recurrent pneumonia. And this is, I think, a CT scan and contrasted CT. Any comment? There is arrow trying to bring your attention to that area. People, please try to comment. You are in an exam. You don't need to be shy. You have to be confident. Even if you're wrong, just comment. Build that confidence. Talk. You're trying to go to exam. You can't keep silent. Exam is an art to act. It's not how much you know. It's what you do with your knowledge. So speak up, talk. Nobody knows who you are, even if you are talking from your mobile. Okay, any comment? Hello, nobody?
I'm very poor on the CT scan or MRI view. I
Just
cannot.
describe what you see. As I told you, you don't need to know.
There is some in the arrow, which one they are showing.
Yeah,
There is
what do you see?
in the X-ray, in the CT scan, there is like a poor aerated area or hyperinflated. I don't know what it is, the dark color.
You see the heart in the right side.
The heart on the right side, correct. And what is this area? You can see the spinal cord over here, vertebral column here, the spinal cord here. So you can see a tissue exactly like the spinal cord. Right? Okay. It's exactly like this tissue, like muscle, right? So it looks like liver, muscle, this area looks like heart. Okay? So it's an abnormal area in here. Okay? So it's a CT scan of the chest. So large, smoothly marginated, hypodense, homogeneous mass that originated from subcarinal region and extend along the right aspect of posterior mediastinum, displacing the right lower lobe of the lung and causing air trapping in the right lower lobe. And it is bronchogenic cyst. But it also can be esophageal duplicated cyst. It can be neuroenteric cyst, and it can be lymphangioma because it's a soft tissue. Okay?
Okay.
Pericardial cyst. There is an annoying voice. Please, whoever is, I think, who's that? Either Surah or Sharwat Yusuf and Usman. Can you please mute yourself?
Yes.
Can you?
عثمان طيب عثمان.
Okay, I muted everybody. Please answer and then mute yourself. Unmute yourself or go to a quiet area. Okay, so 3-month-old boy presented with rapid noisy breathing since birth, difficulty in feeding, dry cough, and he became cyanotic or blue and cried, tachypnea and tachycardia, and there is tracheal shift to the right on the exam. And this is the X-ray. Can you please comment and don't keep quiet? Comment, there will be no punishment, there will be no mark.
There is the hypertranslucency of the left side of
That's
the
correct.
chest.
There is hyperlucency compare right and left. Very good.
Compressing the mediastinum and the heart and the trachea.
Correct. There is a shift. There is compressing down. There is compressing of the lung and compressing of the heart.
Yes.
That's correct. The lung is pushed down. There is cyst, and the cyst is separated. You can see the
Yes,
cyst.
but not there is no complete translucency, so it's maybe emphysema or
So
it's
you can
not
see that
pneumothorax.
there is lung tissue here is not pushed, and there is translucency, and there is separated, and the lung is pushed from here. Okay, and you're right, there is a difference. That's very good. So if you say that in the exam, even if you don't know the diagnosis, that's very good. So what is your differential diagnosis?
Congenital emphysema or cystic adenomatoid malformation.
Cystic adenomatoid malformation. Wow, who said that? Surah.
Yes, me.
Okay. Okay. I'm going to tell you something about cystic adenomatoid malformation. Now, cystic adenomatoid malformation is not a cyst, unfortunately, and it will not appear as a cyst. Can you turn off your voice? No, mute your mic. So, cystic adenomatoid is the type 4. Aya, can you turn off your mic, please? So the, cystic adenomatoid, although it's cystic, it does not appear cyst. And it's a part number 4, type number 4, or CPAM, because before we call it CCAM, and now we call it CPAM. It's congenital pulmonary airway malformation. And the type 4 is cystic because previously they thought it's adenomatoid all, but then they discovered it's not adenoid, only type 4, and there are 3 types. And mostly they discovered with increased echogenicity, not increased lucency. Okay, so when you have, it's very clear. I think whoever told me in the first, it looks like emphysema. It looks like emphysema. It's not like cyst because it's filled with air. And remember, cystic adenomatoid, it won't be filled with air. So it's not cystic adenomatoid, not type 4 of CPAM. If I'm in neuro, I would say CPAM or congenital pulmonary airway malformation. And type 4 is the cystic adenomatoid, which is very rare and very poor prognosis because I have malignancy tendency. But this is like, you can see the lung is pushed here, the lung also in here not pushed, the heart is pushed, and it's full of air. So I would say it's emphysema. If I say emphysema, I would get 50% of the mass because this is, I think it's a congenital emphysema. Chest X-ray and coronary CT scan demonstrate localized hyperinflation of the left upper. And this is congenital lobar emphysema. This is definitely not CPAM. CPAM, they look completely different than that. It's not air. You guys enjoying it or it's boring? You need to stop.
I'm enjoying it.
Okay. Because I just prepared it yesterday. I didn't have time to prepare it. Okay. You have poor connection. That's okay. Okay. So let's go to case number 15. A 9-month-old boy presented with a chronic cough and also failure to thrive. Sweat chloride testing more than 60. Nine-month-old boy presented with chronic cough, failure to thrive, chronic problem, sweat chloride test more than 60 milliequivalent per liter. This is the X-ray. Now, I don't want diagnosis, I want description. I know it's a cystic fibrosis because the sweat chloride test, I put it there. I don't want the diagnosis, I told you. You will fail in the exam, Lily and Rada. No, don't give me differential diagnosis.
This is centralized X-ray. It is hyperinflated chest.
Hyperinflated chest, I agree with you. How do you know it's hyperinflated? Can you tell me?
Because by counting the ribs and the flattening of the diaphragm.
How many ribs you counted?
Here we are counting 1, 2, the giga. 1, 2, 3, 4, 5, 6, 7, 8, 9. More than 9.
More than 9. How you diagnose? How you diagnose hyperinflation by the number of ribs? Like what is the number that tell you it's hyperinflated?
When it is goes more than 9.
More than 9 or more, that's correct. What else it tells you hyperinflated?
Flattened diaphragm.
The diaphragm is pushed down. That's very good. What else? Are more signs?
The heart shadow will be like, how to say that? Narrow.
Small. Easy. Narrow. Small heart, right? A heart looks small. Okay?
Yeah. Yeah.
So that is or narrow, as Lily saying, narrow mediastinum. So, okay, there is hyperinflation. What else there is? What else?
What else?
There is increased intracostal,
non-homogeneous.
but they are not symmetrical. If you look on the left, some of the ribs are crowded, and here it's open. So there is increase, especially in the lower area. So it's more lowerly affected than upper. Upper, it looks more good space. The lower become very displaced, and is not symmetrical on both sides. So the inflation is really on the lower side. What else? What are these?
There is not
What are
non-homogeneous
these lines?
opacities also.
Sorry, who's talking? Sinan?
Yeah, there is non-homogeneous opacities also in the right upper zone, or
Correct.
in the upper zone of the right lung.
It's non-homogeneous. I agree with you, but also you can see these dots.
Yes, these dots also.
And you can see these lines.
Bilateral.
Yeah, what is these lines?
Vascular markings.
Dilatation?
You know, you can see this is an airway, right? This is an airway, right? You see here is an airway. And also you can see this. See, this looks like this, right? So what is it?
Bronchial
Yes,
dilatation.
Bronchioles.
Bronchogram.
Dilated bronchioles. This is dilated bronchioles or dilated airways. I don't know whether it's a bronchioles or not. Okay, Osman, Muna, you just guys jumping, okay? You'll become dangerous in the exam. Osman, Isa, and Muna. So don't give diagnosis. Don't say bronchiolitis. It's very hard to know it's a bronchiolitis. I would say dilated small airways. Just always be politician. Be a liar. Like why the politicians are good? Because they lie. So remember, you don't need to say the truth. You don't need to tell the examiner that you know. Just tell the examiner in a way that will never make you wrong. So don't jump, okay? Always use smooth words, okay? Don't jump. So I would say yes, there is dilatation, okay, of the small airways. I won't say it's a bronchioles. Yes, dilated lower airways. I agree with you. It's a softer than yours. It's more like more sharp word when you say dilated bronchioles. Okay, what else? Anything else?
The lower lobes.
Yeah, well, it's hyperinflated on the lower. There is diffuse. There is increased density in dots area. There is bronchial dilatation. So bilateral diffuse interstitial thickening, peribronchial cuffing with bronchiectasis, nodular density of the mucoid impaction with upper lobe predominance. Remember, the case is 9-month-old boy present with a chronic cough, failure to thrive, and sweat chloride is positive. So the diagnosis is cystic fibrosis. Okay, number 16, 4 weeks old boy presented with persistent dry cough. And this is the X-ray. Any comment? No? There is arrow and there's star.
Yeah. X-ray is sterilized and there is poor aeration.
Remember, this is 4 weeks.
Yeah.
So what is this?
Thymus. And this is
thymus. This is thymus, that's correct.
And this arrow is a sale sign.
Sale signs, yes, you are correct. Of the thymus. What else?
But there is a difference in the aeration between left and right.
Okay, and the baby has, remember, the baby is resistant with dry cough.
Yeah.
Okay.
It looks like
okay, somebody's texting me.
The shifting of mediastinum to the right.
Correct, yes.
And I don't see bronchogram in the left side.
Okay.
What else?
So in short, can you short it? Like, can you give me a short sentence about the case?
I think maybe emphysema, because it is it's shifting to the right side, everything, and it is almost going to
Remember,
the
he presented with dry cough.
dry cough.
Do you see it?
Yeah.
And why it's not CPAM? So remember, this is normal lung, this is normal lung, this is thymus, and this is the mass. So CPAM and sequestration, they look exactly same on the X-ray. CPAM, which is 4 types, and the type 4 is the CCAM, or the cystic adenomatoid malformation. Although it's cystic, but does not appear like hyperloid, it looks like dense structure. The sequestration, there is a differential diagnosis, of course, which one is which, and usually the echo can differentiate because this take from systemic, this take from the pulmonary, this one is within the lung, the sequestration is outside the lung. And you can see how you differentiated from the CPAM. You can see how somebody's texting. Oh, you can go. So you can see the lung very well silhouette from the structure, which means the structure is not from the lung, and that's why it's a sequestration. If it's CPAM, it won't be sharply demarcated from the lung tissue. Okay. Number 17, 6-year-old girl presented with sudden onset of severe cough after playing with toys. What's your differential diagnosis?
Foreign body.
Foreign body. I agree with you.
Foreign body as
what do you see?
there is Victoria here. Can I speak?
Yes, go ahead, please.
There is a sharp needle-like structure.
Correct.
In the left
yeah,
side.
there's a sharp, straight, small size.
And also, there is maybe subcutaneous emphysema.
There is increased lucency on the right, on the left, more than the right.
Yeah.
So I won't say emphysema because I can see the lung tissue within it. So I don't see it's an emphysema because you can see the lung tissue.
Yeah.
Yeah.
Subcutaneous, I mean emphysema.
Oh, subcutaneous, I don't see it. Where do you see it?
The upper arrow.
Oh, okay. I don't see it.
The upper one.
Okay. Okay, so let us speak with Galaxy. I don't know how to convince these people to not join with nicknames. So let's go to Galaxy. Who's Galaxy? Where is Galaxy? Galaxy, do you hear me, please? I'm going to remove you. I cannot keep somebody named Galaxy because I need to know who I'm speaking to. So I've allowed you in to tell you you have to change your name. I have posted that zillions of times. I cannot allow people with nicknames. So please change your name, go out, change your name and come back. Galaxy, do you hear me? Okay, I think it went out. Okay, so radiopaque object located in the left stem bronchus, slight peripheral hypertransparent lung. As you said, exactly from hyperinflation or air trapping, but is not emphysema because I can see lung tissue inside it. Okay, so remember, please, do not diagnose, just describe. Okay, number 18, 9-year-old boy accidentally swallowed a pin as shown by X-ray. Do you see the pin? Do you guys see the pin?
Yes.
Yes.
Okay. So this is the difference between the pin on the trachea and the pin in an esophagus. So this looks like in the esophagus.
Yes.
Okay. And the reason why incidence of vagus, it's below the bifurcation. It's a central. Okay, and its orientation. Okay, number 19. An 11-year-old girl presented with chest pain, cough, shortness of breath, and weight loss, night fever, and excessive night sweat. What's your differential diagnosis? Sumaira, please mute yourself.
Tuberculosis.
Maybe
Tuberculosis. TB.
Yes,
Lymphoma.
chronic infection.
Lymphoma.
Very good. I would not say,
Lymphoma.
yeah, remember, be soft. Don't be focused. Be safe. So it's a chronic infection. That's what I would say. I won't say it's a tuberculosis. It's mostly tuberculosis, I agree with you. But if you guys jump to the diagnosis, you will be dangerous pediatricians. So just remember to be politician. Always find a way to go back. So if I am in a position, I would say chest pain, cough, and shortness of breath, and there is weight loss. There is night fever. So it's an infection, and it's a chronic one. And it's most likely, maybe I'm wrong, tuberculosis. Okay, so the examiner will know that you know, but if you're wrong, you can go back. So please don't jump to diagnosis. That is one of the major mistakes you do. Always be politician, be vague, be diplomatic. Don't be focused, always find a way to go back. Even if in your life, never say I know. Say maybe, mostly, okay? But I think you are right, you guys are right. Can you describe? Can somebody describe to me? There's arrows to help you.
Opacity in the upper lobe of the right lung.
Yes, there is, yeah, there is opacity in here, you're right.
Homogeneous opacity in the upper lobe of the right lungs.
Upper right lobe, yeah.
There is a wide mediastinum.
There is widening of mediastinum. There is something wrong with the mediastinum, I agree, but I think it's mainly because of this.
Yeah, shifting.
Yes, and it's appear here very clear.
Yes.
And there is jet black lower
lower lobe.
There, Sumaira, you're mixing between. Okay, I'm just gonna correct your language. It's lobe, not lobe. Okay, there is lobe, there is lobe. Okay, go ahead. What is more?
lymph nodes.
Mostly yes. So in large mediastinal lymph node, there is hepatomegaly. Show hypermetabolic right parenchymal lymph nodes. Okay, so the diagnosis is what?
Hodgkin lymphoma.
So you all were wrong. But if I am in your position, I won't be wrong. Got it? If I am in the exam, I will not fail, but you will fail. Despite I was wrong too.
Yeah, because you will not tell the diagnosis, you will describe.
Yeah, I'm because that you will be dangerous. I won't be dangerous. Because you will do something, you will go to and you will miss the diagnosis. I won't miss the diagnosis. So what I said, it looks like a chronic infection. Okay, it looks like a chronic infection because it's in a, but mostly maybe tuberculosis, but I might be wrong. So I did have a way to go back. Okay, so it wasn't tuberculosis, it was lymphoma.
Yeah.
Okay, 5-year-old boy present with high fever, cough, tachypnea, and grunting. Crackles on the right side of the chest. So tell me a differential. Tell me what you think of.
It's possible that he's a 5 years, he's having a fever and cough and grunting of atypical infection.
So it's an infection, right?
Tissue is
But we don't know whether it's an acute or chronic because he didn't say, right? We don't know whether there is weight loss, and he didn't tell us the duration. But we know it's a fever and cough, and there is crackling, so it's mostly infection.
Infection, yeah.
Remember, don't say anything else. That was telling you it's an infection. Don't say anything else.
Yeah.
Okay. So here's the X-ray.
In X-ray, we see
view and lateral.
in the right lung.
Okay.
Poor cardiac shadow in the right side. Not well-defined cardiac shadow in the right side.
Okay.
And
if you look at the lateral, it's not contrasted. It's not within the heart. Okay.
Yeah.
And it does not look like a mass because it's a wedge shape. You see, it started from the middle as narrow and then widening when it go out. So it's not a mass, right? It's here look like opacity, but it does not look like it's a mass, right? So that's what I've said. And with fever and cough, and then so mostly look like a pneumonia.
Pneumonia.
Right middle lobe with ciliary to the right heart border. Opacity straight upper border suggests limitation along horizontal fissure. Yeah, that's the horizontal fissure. So it's a right middle lobe pneumonia.
Okay.
Okay. So let's speak with Asma because Asma is writing her name wrong. Asma, do you hear me? Asma. Asma. Asma, do you hear me?
Yes, I am hearing you.
Can you please put your full name? Asma what? Don't put just your first name. If you can kindly do that, so I know with whom I'm speaking. Thank you very much.
Okay. Okay.
Okay. Case 21. 10-year-old boy, an immigrant from South America, presented with cough, fever, weight loss, night sweat. Cough, fever, weight loss, and night sweat. His PPD test is 17 millimeter in duration, with significant crackles on the left upper lobe. Now, this one is almost telling you the diagnosis because we know it's a chronic infection. We know it's from an endemic area. And he's telling you the PPD test is more than 17 millimeter. So even without risk, it will be considered positive. Yeah, so here's the the X-ray. Any comment? I'm gonna go back so you can read. It's crackles on the left upper lobe. Left upper lobe. I think this is before and after treatment.
This is a poor aeration in the left upper lobe with tracheal deviation to the left.
Okay. I won't say a big deviation, right? It's still in the center and the clavicle looks okay, but I agree with you, the inflation on the right is more than on the left. And it's cured after that. If you see if the X-ray, the other one is cured. And I don't see much of a difference. The trachea looks like same on the two pictures. Yeah?
Yeah. I see hypertension on the right side.
Yeah. So this is tuberculosis, which confirmed by sputum test. Okay. Complete resolution after 6 months. You can see it.
And where is the scar in the left lung, doctor? Where is the scar exactly? I don't see that.
1 minute. Let me just people is attending. You don't see the scar? You don't see this area?
Yeah, I see. That's the meaning of scar?
Yeah, mostly the scar when you have collapses, you see a collapses and increased density in an area. So it's in here. Okay. Asma, still you didn't change your name. So if you can go out, put your full name and come back, please. Okay, somebody's texting me. Case number 19, what is the diagnosis? Oh, there are two cases. One is neuroblastoma and one is medulloblastoma. So, but the pictures are of the same because I did it yesterday. So probably I didn't put the pictures for, that's why I jumped it. So one of them was a neuroblastoma, the other one is medulloblastoma.
Okay, I sent it mine.
Okay, great. Thank you very much. Well done.
Okay.
Okay, I'm